Approach to a patient with inguino-scrotal swelling. History. Gathering a thorough history is essential to narrow down the differential diagnosis. Presenting complaint. Onset acute, gradual. Duration. Progression, increasing in size, stable, or fluctuating. Pain, sharp, dull, constant, or intermittent. Relation to activity, straining, or position changes. Associated symptoms. Redness, fever, or systemic symptoms. Gastrointestinal symptoms, vomiting, constipation, or abdominal pain. Urinary symptoms, dysuria, frequency, hematuria. Past medical history, history of trauma, surgery, inguinal hernia repair, or chydopexy. Recurrent swelling or infections. Chronic conditions, e.g. COPD, ascites. Social history, occupation involving heavy lifting. Sexual history and risk of sexually transmitted infections. Family history, inguinal hernias or testicular cancers. 2. Examination, general examination, signs of systemic illness, fever, pallor, dehydration, vitals, especially fever or tachycardia, suggesting infection. Local examination, inspection, symmetry of the scrotum, skin changes, redness, swelling, ulceration. Visible peristalsis, rare but can indicate bowel involvement. Palpation, sight, size, shape, and consistency of swelling. Reducibility, swelling decreases with gentle pressure or lying down. Cough impulse, increased swelling with a cough, suggesting hernia. Tenderness, suggestive of torsion, orchitis, or incarcerated hernia. Transillumination test to differentiate cystic versus solid masses. Examine the inguinal region for hernias or lymphadenopathy. Examine contralateral testis and abdomen, ascites masses. 3. Differential diagnosis, hernias, reducible or irreducible inguinal hernia, strangulated or obstructed hernia. Testicular causes, hydrocele, varicocele, epididymitis or orchitis, testicular torsion, testicular tumor, scrotal wall, hematocele, pyocele. Miscellaneous lymphadenopathy, lipoma of the cord, femoral hernia. A4 investigations, laboratory tests, complete blood count CBC for infection or anemia, inflammatory markers CRPAR for infection or inflammation, urinalysis to detect urinary tract infections or hematuria, tumor markers alpha fetoprotein AFP, beta HCG, LDH for suspected testicular cancer, imaging, ultrasound scrotum to evaluate testicular and extratesticular pathology, Doppler ultrasound to assess blood flow, torsion, varicocele, CT MRI abdomen and pelvis. If malignancy or complicated hernia is suspected, special tests. Fine needle aspiration or biopsy for suspicious masses. Laparoscopy for diagnostic purposes. Rare. Treatment. Hernias. Reducible. Elective surgical repair. Irreducible strangulated. Emergency surgical repair. Hydrocele. Conservative for minor cases. Surgical hydrocelectomy for symptomatic cases. Varicocele. Conservative or surgical ligation embolization, especially in infertility. Epididymitis or orchitis, antibiotics based on likely pathogens, e.g. ceftriaxone and doxycycline for STI-related infections. Supportive care, scrotal support, analgesics. Testicular torsion, surgical detorsion and orchiopexy, emergency. Testicular tumor, radical orchiectomy, further treatment based on histopathology, chemotherapy, radiotherapy. Scrotal wall infections, antibiotics and incision drainage if abscess is present. Others, treat underlying causes, e.g. ascites management for secondary inguinal hernias. Follow-up, postoperative or post-treatment follow-up for recurrence, complications, or long-term care. This systematic approach ensures accurate diagnosis and effective treatment.